Good morning, everyone. Welcome to our core Appendix Q presentation. I would like to welcome CMS Region 10 Office Patrick Thrift, Linda Harris, and Terry Aoki with us this morning, and joining with Residential Care Services to do this presentation. I would like to also thank upfront to Leading Age and also WACA associations for all the help and participation in pulling this presentation together. It'll probably take about an hour and a half. It might be a little shorter, it might be a little bit longer. And I'd like to just upfront say a few things before I go around and do some introductions. I would like everybody to know that this is going to be recorded, and so in doing so, we want everyone to know that it will become a public record. It will be posted later. It will be subject to disclosure under the Public Records Act if it's going to be recorded. And we ask that no client-specific, confidential, or personal information be discussed. If you do interact with any of the presenters, like asking questions or making comments, I do want everyone to understand that your contributions will become a part of this public record, and that you are aware that you are giving consent to it being recorded. So I would also like to say that I would ask everyone to hold their questions to the end after our presentation. There's about 45 slides that we have here in our presentation. Do encourage you to write any questions that you have while we're presenting so that you can ask them at the end, and then we'll have everybody raise their hand and you can write your questions in and we'll provide the answers in that. So I would like to first start out with introductions from CMS Region 10 office. So Patrick, Linda, Terry, would you like to go ahead and introduce yourself? Thank you.
Yes, hi, good morning, everybody. My name is Patrick Thrift. I'm the branch manager for Survey and CLIA branch.
Good morning, this is Linda Harris. I'm a federal surveyor in the Seattle Regional Office.
Hi, this is Terry Aoki. I'm a federal survey with CMS.
Thank you, everyone. I'd like to go around here and everybody do introductions here from the RCS Residential Care Services Division. Dina, do you want to start?
Sure. Good morning. I'm Dina Long-and-Grimes, Nursing Home Compliance Specialist.
And this is Rebecca Kane. I'm the nursing home trainer for RCS.
And I'm Marcy Caird, and I also work in the RCS training unit.
Christine Kubiak, Nursing Home Program Manager.
Jerry Jones, Training Unit Supervisor.
This is Ty with RCS.
And I'm Beth Schlemmer. I'm Office Chief of Field Operations and Residential Care Services. I have oversight of the nursing home program in the state. Again, I do appreciate everybody's attendance. We had planned throughout the tail end of 2018 and all of 19 and having a joint IJ Core Appendix Q training for the new revised Appendix Q that we have with CMS and Residential Care Services to provide this presentation to the association. So we're happy to do that this morning. We're going to start now with our presentation. So Didi, you want to start out?
Sure. So the objectives. These are the things we are going to cover here this morning for you all. So we're going to just mention a little bit about the online training for the immediate jeopardy through the ISTW history of immediate jeopardy. So the changes that kind of came about when the Appendix Q was going to be updated, some of the key definitions, introduction to some of those core guidelines to determine an immediate jeopardy, and some of the components of the immediate jeopardy, and a process that should be used in determining immediate jeopardy, the calling of the immediate jeopardy, then the removing of such, and then the approval of a removal plan, and then just some of the revisions to Appendix Q. So, want to advance the slide for me, please? Thank you. So this first one is just a link for individuals to go on to the survey training, and this immediate jeopardy training has been on the CMS website for some period of time. It's about a 45-minute training, and we will be covering some of the information that was in this training, but we're going to go into a little bit more depth in this particular training. So this is a link for you guys if you have not already done so. And then this is just kind of an example of what you'll see when you get onto the ISTW site. You're a survey, you're a provider, so you'd be clicking on there in order to open this up. And then the next slide kind of tells you, you know, pick it out of the course catalog, and then you'd be able to launch that 45-minute course.
And this is, once you do all that, what Gina is saying, this is what will then pop up on your screen and will cue you that you're actually in there and you're launched, and you can go into this training about immediate jeopardy. And once you get to that launch course, here's another screen. We're taking out time this morning to show you what will come up when you get in there as you journey through this training. And it'll provide you information exactly here what you are going to see with that training. Okay. I'm going to take over now here and talk about the long journey. So Appendix Q was created originally in 2004, and in 2012, there was a work group to figure out how this was going to be revised and updated, because things do change over a period of time. An Immediate Jeopardy Summit was done in December of 2017 with all of the regional office, the state agency, quality, safety, and oversight group, divisions were developed, you know, for this core Appendix Q and the template and all the subparts that go along with it. So Core Appendix Q actually finally got all finalized here in February 27th of 2019. So all of that was rolled out on that particular day. And so next, it's some of the changes that happened. So one of the big reasons was there were some words in there that were needing to be changed a little bit to line up with regulatory definitions. So we removed the word culpability and potential, and replacing those with the words immediacy and need to take immediate action. And in the new Core Q appendix, we define key terms like serious harm, likelihood. We also are going to focus on their three components that the survey teams have to prove for the immediate jeopardy to actually be identified. And those are non-compliance with one or more federal tags, that there's the potential of serious harm and or death, or the likelihood that serious harm and or death may occur, and the need for a facility now to take immediate action to prevent any future incidences. And also added the component about using the psychosocial harm and reasonable concept for persons who may have dementia and memory impairment and may not actually be able to show that harm has occurred. So, and then clarifying guidance to ensure facts about a situation are very specific to a regulation. So there aren't going to be any automatic citations at any regulation. So each immediate jeopardy would need to stand on its own. We wouldn't indicate that if we have an immediate jeopardy and an F-tag under care and services, that we would also have an immediate jeopardy under a administration or governing body tag. Those, they have to stand on their own. Also clarifies or differentiates between the accepting of a removal plan and the immediate jeopardy actually being removed. Specifies what
we should be included in the 2567 for consistency, so they look similar and they're easy to follow and understand. And also included this IJ template that can be given to a provider, supplier, or laboratories, and those can actually hopefully help that provider determine how they need to start the removal plan process. Here are some of the definitions that came up here. So it's likely or likelihood. So it means the nature or extent of the identified noncompliance creates a reasonable expectation that an adverse outcome resulting in serious injury, harm, impairment, or death will occur if it's not corrected. Noncompliance, of course, we all know that just means the failure to meet one or more of the federal safety and or quality regulations. And then psychosocial in this situation refers to the combined influence of psychological factors and the surrounding social environment on someone's physical, emotional, or mental wellness. And the recipient, it's a person, whether it's a patient, resident, or client, however you term that in your entity, who receives care and services from a Medicare and or Medicaid participating provider or supplier. And the recipient at risk is the individual who, as a result of the noncompliance and consideration of their physical, mental, psychosocial, or health needs and their vulnerabilities, is likely to experience some kind of serious outcome or may have already experienced that outcome. And the removal plan, immediate action, includes all actions the entity has taken or will take to immediately address the noncompliance that resulted in or made serious injury, serious harm, serious impairment, and or death likely. So we'll be going over these slides later. We're just hitting you with the definitions here in the beginning. So serious injury, serious harm, serious impairment, or death are the adverse outcomes which will result in or are likely to result in death, a significant decline in physical, mental, or psychosocial functioning. And it's not solely due to any normal progression of a disease or aging process. So if something is occurring with an individual that would normally be occurring in their process, that may not be an immediate jeopardy. A loss of limb or disfigurement, avoidable pain that is excruciating, more than just a transient type of pain, and other serious harm that creates life-threatening complications or conditions, such as maybe, for an example, might be life safety code. If the fire system is not working effectively, that could be serious harm that could come about because if there was a fire, the system wouldn't activate as needed. Substantial compliance. You should all be familiar with this. So substantial compliance is one or more standard level deficiencies with an acceptable plan of correction, or the deficiency cited at a severity level 1, which is an A, B, or C, with an acceptable plan of correction for B or C level deficiencies. So in order to be in substantial compliance, you have to meet these criteria. I'm going to pass it on to Beth.
So now we'll go on to what triggers a need for surveyors to consider an IJ. When noncompliance has caused serious injury, harm, impairment, or death, or when noncompliance makes serious injury, harm, impairment, or death likely, serious injury, serious harm, serious impairment, or death are adverse outcomes that result in or are likely to result in death, a decline in physical, mental, psychosocial functioning, loss of a limb or disfigurement, or avoidable pain that is excruciating and more than transient pain, or other serious harm that creates life-threatening complications and conditions. What's important here is the word trigger, and what's also important in here, you can see in the bullets, is the word serious. What do you need to know about an IJ? What steps should be taken when an IJ is suspected? There are three components in the new revised Core Q that we want to get your attention focused on. First is noncompliance. Second is serious harm has occurred or is likely to occur. Third is the need for the entity to take action to prevent serious harm from occurring or reoccurring, which means you need to take immediate action. Then another step is to consult with the state agency or regional office if part of the process, if they concur. This is where the state agency, if they recognize there's an immediate jeopardy, they will be talking among themselves, and then they may also bring in the regional office to discuss the immediate jeopardy. And then the state agency will inform the entity that the IJ exists at the time of the survey using the new immediate jeopardy IJ template. What do you need to know about an IJ continuing? How is this entity informed that an IJ exists? The state agency teams or complaint investigator will inform the entity during the survey using the IJ template. The IJ template will be very complete about stating upfront those three components I just went over, what that non-compliance is, what that serious harm or likely serious harm is, and what the immediacy is for immediate action. Once an IJ has been called by the state agency with the provider, we will request a removal plan from the provider. And you will be receiving from the state agency and the regional office certification letters about the immediate jeopardy being called in the building. We want to focus a little bit more on the reasonable person concept for psychosocial and mental harm. Nina had brought this up earlier a little bit. It's important to understand that non-compliance rising to the level of immediate jeopardy does not always result in serious physical adverse outcomes, but it could also result in the recipient's mental or psychosocial well-being being impacted. If the surveyor is not able to gather information from a recipient's response to a provider's noncompliance, the surveyor should apply this reasonable person approach. I want to go over the key components again of the IJ. There must be noncompliance with one or more federal health, safety, and quality regulations. That's where it begins. There is noncompliance. There's failed practice. And then second, that failed practices has caused or made likely to cause serious injury, harm, impairment, or death. And then there's immediacy to it, which means immediate action is necessary to be taken by the entity to prevent the occurrence or reoccurrence of serious injury, harm, impairment, or death to one or more recipients. So we have here for you a little pictoriogram there that really highlights that IJ has to have all three components. And it has to start out with noncompliance, and then you have to be able to answer, is there serious harm, injury, impairment, or death that it has occurred or it's likely to occur, and then there has to be immediate action to remove that IJ. Those three components have to be there.
All right, I'm going to take over now. So the process for determining an immediate jeopardy. We have to have verification of all three components as that just had mentioned of the immediate jeopardy to determine if it is identified. There has to be sufficient evidence gathered in the investigative process using all of our applicable tasks from our state operations manual, the SOLM, and relevant Appendix Q to establish the noncompliance with the federal health, safety, or quality regulations. We have to have all three requirements met, and they must be answered yes. So, of course, noncompliance usually is the easiest one to do because Usually that can occur with failed practice. So that's, the first is always a yes, but we have to determine that the second category regarding the seriousness of the situation is also a yes. And the third category would be that if the facility doesn't take an immediate action, that they will, something bad will happen again or could happen in the future. So those are the pieces that have to be all answered yes. In determining immediate jeopardy, it's not necessary to prove when serious harm will occur or that it will recur within a specific time frame. So we're not looking at an individual saying, oh, this is going to happen in the next 10 minutes, 2 hours, 2 days. That's really, we know that at any given point in time, if something doesn't get remedied and fixed and some actions aren't taken, something serious can happen. So we definitely are not looking at time frames. And we need to sufficiently show that the harm has either occurred or is likely to occur. And professional judgment comes into this as well, taking into account the nature and the scope of the noncompliance, the vulnerabilities of the recipients that are at risk, and only has to be one recipient, doesn't have to be all, and other relevant factors that are going to help us determine whether that serious harm is likely to occur if no corrective action or inadequate action is taken. So sometimes maybe a facility might have done something, but it's not adequate enough to really protect those recipients. So understanding the serious component. So on this continuum, harm is you've got your less serious to your most serious. So that's kind of how we are looking at this from the immediate jeopardy standpoint, is something that is less serious, probably is failed practice, but more than likely is not going to rise to that immediate jeopardy level. But as we go forward on that continuum and things are getting more significant, more serious, then we are getting closer to identification of an immediate jeopardy. So at some point, the harm that is caused or made likely should be determined. So at some point, we're going to have to decide this is a serious situation, serious injury, harm, or impairment, and or death. So understanding this is we're looking at it again from a continuum of when we are going to get to that serious level. A couple of examples just to bring you forward on immediate jeopardy. So a temporary power outage for a nursing home that provides care for ventilator-dependent recipients. The temporary power outage would have life-threatening consequences if adequate contingencies have not been implemented. So in that kind of a scenario, say that the facility's generator is not up to snuff and it's not going to provide the power to those residents as the power outage goes out. That is immediate because those residents are not going to be able to sustain life. So that's very serious, and there needs to be contingencies in place that are going to remedy that right away. Another example, a nursing home fails to develop and implement antibiotic stewardship protocols, including reporting culture and sensitivity laboratory tests for an infection to that practitioner to determine the most effective antibiotic modality. And it would have life-threatening consequences for residents without clear protocols or managing infections. So you've got a situation where maybe the facility doesn't have a good antibiotic stewardship process or protocol. The individual does not get on a correct antibiotic, and that individual ends up being sent to the hospital in critical condition and may have lifetime effects or may not survive that because there wasn't a good system in place for them to manage those infections, and maybe one individual was only impacted initially, but it can happen to anybody if there's no good system in place in order to process that.
Thank you, Dina. This is Beth. Up to this point here in our presentation, we have identified the changes that have been made to the Appendix Q. We have identified definitions that we're now using for immediate jeopardy situations. We brought out about the reasonable person component of psychological harm. We brought out about the 3 particular areas that need to be looked at in order to call immediate jeopardy. And up to this point now, we're ready, if we have called an immediate jeopardy, how we document that on the immediate jeopardy template. And so I'm going to welcome on board here Linda Harris and Terry Aoki to take over here for the presentation and the next slide deck.
Okay, Bet, can you advance the slides? So when calling immediate jeopardy, survey staff completes the immediate jeopardy template in determining the to ensure that the components are met. Once the immediate jeopardy is identified and the template is completed, the survey team provides the preliminary findings to the provider. Some of the, next slide. Some of the key points regarding the IJ template. The IJ template will assist the surveyors in establishing each component of the IJ. The template also has attached to it instructions and the definitions of the key terms. This provides the surveyors with the ability to keep reviewing those instructions and definitions as they're making their determination if an IJ exists. The template also allows the surveyors to clearly communicate to the provider, supplier, or laboratory the non-compliance, the impact or likely impact to the recipient of the care, and the need to take immediate corrective action to prevent the occurrence or reoccurrence of serious injury, harm, impairment, or death. The template is reviewed by the managers to ensure that all elements are present on the template before the facility receives the IJ template. Also, the template provides the survey team, or the survey team will provide the facility a separate template for each F tag associated with the immediate jeopardy. This helps the facility break down those components, and it should help the facility remove the IJ situation, the immediacy. It helps them focus on each of the components that have been identified with the IJ. And it should be noted that the 2567 is the only form that contains the official findings. So the IJ template, the first block contains the non-compliance. And these are the elements that resulted in the deficient practice. Okay, next slide. Did serious harm occur? If yes, describe the harm. Does it meet the threshold of serious? And then a brief summary of the serious adverse outcomes or likely serious adverse outcomes to the recipient. So this second box contains the actual harm or the harm that could occur. Next slide. So the need for immediate action. This is the third box on the right, and it says, and the information here should, does the entity need to take immediate action to prevent serious harm from occurring or reoccurring? Even if the recipient has been removed from the situation, does the non-compliance still exist that contributed to, caused, or was a factor in causing the serious injury, harm, impairment, or death? So an example of this would be a resident, say, elopes from the facility finds the resident comes back into the facility. However, the facility's WonderGuard system is not functioning and the facility hasn't put anything in place to prevent further elopements from occurring. So the IJ would continue.
Okay. Hi, this is Terry Aoki. So I'm going to go over the IJ template exercise. So the next slide. So this is, there's a lot of words here, but basically to better understand the IJ template and the 3 components of the IJ, we wanted to go over this exercise. So I'm going to read off the key components of the scenario or the exercise. So this is a long-term care facility, and the deficient practice is under F760, which is the facility must ensure that its residents are free from any significant medication errors. So in this exercise, there's a resident on Coumadin, which is an anticoagulant medication used to treat or prevent blood clots in veins or arteries. And while on Coumadin, the staff were supposed to check the resident's ProTime and INR, which is a test to determine how long it takes for blood to clot. So the staff were to check the resident's PT-INR and to contact the physician with the results before administering the resident's next dose of Coumadin. Next slide. So here you'll see there's, this is kind of the record review component of the surveyor's investigation. But basically, the resident's Coumadin was not held. The resident's INR was greater than 8, and the resident started bleeding. The resident had gastrointestinal bleeding. As a result, the resident was transferred from the long-term care facility to the hospital emergency room. While in the emergency room, the resident's laboratory work showed low blood levels with treatment required for bleeding, including vitamin K and fresh frozen plasma. Next slide. So the next slide shows the interviews. And the interviews, essentially, the key components is the interview with facility staff showed that the physician's orders to hold the Coumadin were not placed in the computer or passed along in report. The resident continued to receive Coumadin, but shouldn't have. When the resident started bleeding, the physician was called with orders to send the resident to the emergency room. Interviews were conducted with the physician, which showed that the physician's orders to hold Coumadin was not followed. The staff also did not recheck the resident's INR for Coumadin clotting times. Because the physician's orders were not followed, bleeding occurred. The resident could have had a stroke or exacerbation of other medical issues. And the interview with the corporate consultant, the very last interview, revealed that the nurses were supposed to follow physician's orders. Okay, so the next slide is the, from that exercise, this is how the IJ template would be completed. So we using the scenario that we just reviewed, the first component, as Linda covered, is the very first component of the IJ is, was there noncompliance? Did the facility fail to meet federal regulation? And if yes, what is the tag and what is the failure? So the response in the IJ template, the middle column is, the response is for the noncompliance component is yes, there was noncompliance. And then on the far right-hand column is the preliminary factual analysis, which demonstrates when key components exist. So it's a short narrative description of the noncompliance. So here it's, and you do need to put the F tag. So it's F760 is the federal tag. So the facility must ensure that residents are free from any significant medication errors. And the failure is the facility failed to hold Coumadin as directed by the physician and follow physician's orders for an INR recheck, which is a significant medication error. Next slide. The second component of the IJ template is the serious injury, serious harm, serious impairment, or death. So you can see the template identifies, the question is there evidence that a serious adverse outcome occurred or a serious adverse outcome is likely as a result of the identified noncompliance? The result on the IJ template for the second component is yes, and that's noted in the middle column. And on the far right column, the factual narrative analysis to demonstrate whether the key component exists is serious harm, including gastrointestinal bleeding, being sent to the emergency room, being admitted to the hospital, requiring treatment, including vitamin K, and fresh frozen plasma. Next slide. So the last and the third component of the IJ to determine IJ is there a need for immediate action? Does the facility need to take immediate action to correct noncompliance that has caused or is likely to cause serious injury, serious harm, serious impairment, or death? The response in the IJ template for immediate action is yes, and that's the middle column. And so the factual narrative analysis to demonstrate whether the key component exists is there is a need for immediate action to ensure residents who take Coumadin are given it as ordered by the physician, and that INR checks are done as ordered in order to prevent serious harm from occurring. And so for this exercise, the three components of the IJ template were met, and therefore an IJ was determined. So I think at this time, we're going to turn it back over to RCS to review the removal plan.
Okay, Dina is going to take over here with the slide.
Okay, thank you. So the removal plan. So what the removal plan is and then what it is not. So it's a written plan, and it identifies all the actions the entity provider is going to take to immediately address the non-compliance that was identified in the immediate jeopardy, and to ensure no recipients are suffering or likely to suffer serious injury, harm, death, or impairment. So in that written plan, we'll use the example that Terry had just gone over with you in the previous slides. So the written plan would say that the facility was going to create a policy about how nurses were going to follow the physician's orders for the administration of Coumadin or the stopping of that medication if need be, or holding of it. And then also too, when to do the laboratory work, the INR work. So there would need to be some pieces in that written plan that would identify those components, how they were going to implement a policy, who they were going to train, you know, how long that might take them to train, and what residents would need to be, that they would be reviewing all the residents that might be getting Coumadin therapy. So, and then what it is not is, it is not a plan of correction. So it doesn't need to include all the correction of the non-compliance and the 5 components where it goes into how you're going to sustain your compliance after it is corrected and the monitoring of such. So really, we want facilities to work on the immediate pieces right away. And the plan of correction definitely will come when the 2567 and the official document does come up to the facilities. So sometimes facilities may want to tell us what they're going to be doing in the future as well. But initially in that removal plan, what we really want to know is the immediate pieces. What are you going to do right now? And that will help us determine if you have met all of those components. Slide. So, and again, by the entity, it has to include recipients who have suffered, likely to suffer, and the action that they're going to take to alter those systems. So I've kind of just been going over this slide a little bit. These are just the components that we would be looking for in the review of a facility's written removal plan. So approval of this plan, the removal plan. So it's going to be evaluated and approved by the state agency. So what likely happens in this case is you may give us a removal plan maybe an hour or two after the immediate jeopardy is called, but there are still pieces of that removal plan that you need to implement. You might be training, as the example Terry used earlier, you might be needing to train nursing staff on evening shift, night shift, the shift the following day, people who were off the particular day that you were doing your trainings. So what we would be looking at is, first we would approve that you have all the components that we feel you need to remove the immediacy, and we also will be looking at the implementation of that plan. So it may be the likelihood that the harm will not occur again or reoccur. We have to look at that. We may be looking at that information the following day after that plan has been implemented and is in process. And we will always do an on-site through observation, interview, and record review to ensure that all these actions are in effect. So if you have trained all of your nursing staff on Coumadin therapy and laboratory and physician's orders, we're going to go and talk to those nursing staff to see what they know and what they've learned and what that new process is, and are they able to repeat that process back to us to determine that serious harm, impairment, or death would not occur or reoccur in this situation. So if the facility for some reason isn't able to provide an acceptable plan of correction for removal, or is unable to implement this plan, the survey team, we're going to work with the facility to determine that every option is reviewed and to assure compliance is process prior to terminating. We want to engage the owners to assure that they are aware of the consequences of this immediate jeopardy if it goes to this level where there's a difficult time providing a removal plan that is going to work. And we work with the regional office and OGC to determine if no other options exist except termination. So this is something that we would have to do if a facility just could not give us an acceptable plan of correction or removal of that immediate jeopardy. And there would be a plan to terminate any contracts and relocate the residents at this point in time. So there would be the process to close the facility. So it's the Office of General Counsel, sorry about that, is the OGC. So those are issues that could arise if the removal plan is not accepted and there doesn't look like there is going to be the opportunity for one to be accepted in a 23-day period. That's how long a facility has.
So this is Beth. To talk about the removal process of an immediate jeopardy, let's look at the state agency's role. If the IJ is removed prior to the survey exit, CMS 2567 Statement of Deficiency Report is written to include the issues found at the immediate jeopardy level. If the IJ was not removed prior to the survey exit, the state survey agency will provide the regional office with the findings of the IJ within 2 business days. From the regional office's role, when the regional office receives the CMS 2557 from the state survey agency, the regional office will send a letter to the provider with the intent to terminate for 23-day termination. The state agency has a process in place that when we call an immediate jeopardy, we do inform the regional office CMS immediately within 24 hours or the next business day. We want to point out to your attention one of CMS's Center for Medicare and Medicaid Services, QSO transmittals, that was written and revised in July 31, 2019, to talk about the new revisions to the Appendix Q guidance on immediate jeopardy. I would encourage everybody to review this transmittal if you have not reviewed it before, or revisit it again. It's important that providers make sure that you are using the guidance now, the new Core Q, for the immediate jeopardy and not the old Appendix Q anymore. We want to point out that revisions to the Appendix Q, it was revised to reinsert language referring to criminal acts and law enforcement. and when the identified noncompliance is determined to have been caused by or has led to a criminal act, reporting must be made to a local law enforcement, and this must be done immediately upon identification. So everyone is aware of this. Before we go to questions and answers, we'll provide an opportunity for you all to chat, raise your hand to give us, and we'll unmute you for questions. I just want to highlight what we've accomplished here over the last 15 minutes for pointing out to you the changes to the Appendix Q. Dina brought out at the front end here of our presentation that it now aligns with the regulatory definitions of immediate jeopardy, that the words of culpability and potential were removed and replaced with the words immediacy and the need for immediate action. It's brought out key terms, definitions for serious harm and likelihood. It now focuses on 3 components that must be existing that surveyors must prove for immediate jeopardy in order to call an immediate jeopardy, which is noncompliance, serious harm and death, or need for immediate action. And it also focuses and highlights that we use psychosocial harm and the reasonable person concept. Immediate jeopardy does not have to be physical. It can be psychological. It can also be the environment. I want to point out with some of the highlights that we brought out this morning about definitions, and that, again, we want to emphasize about serious injury, serious harm, serious impairment, or death are adverse outcomes that result or are likely to result when there is an immediate jeopardy. So you want to hone in on that serious injury component. Dina had shown a slide this morning that shows a scale to the left where it's less serious harm, and then to the right where it's the most serious harm. And that could be death. It could be a significant decline in physical, mental, or psychosocial functioning. It can be loss of a limb. It can be a disfigurement. It can be avoidable pain that's so excruciating, which is not transient and not addressed. Or it could be other serious harm that creates life-threatening complications or conditions where it warrants that immediate action has to be taken. We brought out this morning also the process for determining immediate jeopardy, that you must have verification of all 3 components of that immediate jeopardy to determine that it is there. We have emphasized that a lot this morning, that you have to have sufficient evidence gathered in the investigative process using applicable tasks from the State Operation Manual and relevant to Appendix Q to establish that there is noncompliance with federal regulations, which is the state agency's role for the investigation process. That there must be all 3 requirements and the immediate jeopardy template that must be met. When Terry and Linda was pointing it out this morning, they pointed out that you either answer yes or you answer no. The state agency, when they do their investigation, must collect evidence to be able to answer those 3 components with yes for all 3 in order to establish an immediate jeopardy. If they answer no to any of them, there will not be an immediate jeopardy. In determining an immediate jeopardy, we brought out this morning, it is not necessary to prove when serious harm will occur or that it will occur within a specific time frame. It's sufficient to show that serious harm has either occurred or is likely to occur. And we also brought out this morning that professional judgment is used taking into account the nature and the scope of the identified noncompliance, the particular vulnerabilities of the recipient's risk, and any other relevant facts to determine whether serious harm will likely occur if no corrective action or inadequate action is taken. And when we're talking about that corrective action, we're talking about that immediate action that needs to be done, not that plan of correction. I want to point out about the removal plan. Dina had brought out that in order to remove an immediate jeopardy, the State Survey Agency will be on site in your facilities to establish that through an investigation. And that investigation will be going out and looking to see if the immediacy of the immediate jeopardy is being removed. The immediacy is the important piece. It's not a plan of correction. And the IJ is about failed facility practice. It's important to know that component. And we're looking to see that there's no further serious harm or likely for serious harm, death, impairment, or injury that's going to occur based on the actions that were taken by the provider to remove the immediacy. Regarding the IJ template, where Terry and Linda had taken up time to give an example of an immediate jeopardy and the evidence, how it was put into the 3 particular sections. That is what the State Survey Agency will be doing. They'll be putting their evidence into those 3 boxes, answering yes. And it doesn't have to be a lot, but it has to be enough that the provider can understand the non-compliance, that they can understand what the serious injury, impairment, a death, or likely serious injury, impairment, or death may be, and that they can recognize the fact that immediate action has to be taken immediately to remove that immediate jeopardy. Dina, any comments?
I
Highlights?
think you have covered it nicely in summarizing.
Linda and Terry and Patrick, any summary comments that you would like to highlight?
No, I think you covered it all, Beth.
Yeah, thank you.
So now we're on to ask our audience there here today with our presentation. Do you have any questions?
Hi, this is Rebecca. It looks like we have some questions coming into the chat box. And then I'm going to go ahead and unmute your line, and I'm going to just go down my list. And then that way you can ask your question and have a little bit of dialogue here with both CMS and us here at RCS. And then if for whatever reason the audio doesn't work, then I can read your question and then the panelists will answer.
So this is Beth. I just want to remind everybody again that this presentation is being recorded and that it is a public record and it's subject to disclosure under the Public Records Act. So we ask that no client-specific, confidential, or personal information be discussed or asked in your questions. And when you're interacting with the presenters, the same, that is not occurring, and that you understand that your contribution is going to become part of a public record. And if you choose to do so in whatever you ask, that it implies your consent being recorded. Thank you.
Okay, the first question, it looks like it's from Edith Morrison. I'm going to go ahead and unmute your line. Okay, Edith, can you hear us and can you ask your question, please? Okay, perhaps she can't hear us, so I'm going to go ahead and just ask her question. It was, do all 3 components have to be met for the IJ to be issued?
Yes, there has to be a yes for each component as in the template. So the non-compliance is the first. That's usually the easiest to answer, yes. This is Dina speaking, I'm sorry. Second is the seriousness of the situation, and that has to be answered yes as well. And then the third is that immediate action needs to be taken in order to do so. That also would need to be answered yes in order for an immediate jeopardy to be called. If one of those 3 components is not answered yes, there still may be failed practice and there still may be a facility citation on the 2567, but it wouldn't rise to the level of an immediate jeopardy if one of the 3 components was answered no. I hope that answered your question.
And Edith, I have your line still open. If you're there, you could ask any follow-up question. Otherwise, we'll move on to the next question. Okay, next we'll go with Jennifer Go Cyan Go. Let's see. Give me just a sec to unmute your line. Okay, Jennifer, can you ask your question, please?
Yes, so my first question is, how does the resident notification look like once an IJ is called?
So
Did they-
this is Dina, and I'm going to actually pose a question to you because maybe I'm not clear on what you might be asking. But what do you mean resident notification? Informing the resident that there's an immediate?
Yes, so the residents that are involved in the potential harm and other residents that, could be involved, how does that notification look like? Would that be coming from the surveyors or would that be coming from providers?
It comes from the providers. So
Okay.
it is the provider's responsibility once the survey team and the regional office may be involved as well, have identified an immediate jeopardy and informed the provider. It's the provider's responsibility to reach out to the impacted recipients' residents in their facility.
Okay. And my other question is there a time frame for when the removal plan should be completed?
This is Dina again, and yes, there is. So when an immediate jeopardy is identified and called, there is a 23-day window.
Oh, 20.
Yes, it's 23 days from the day that it's called, and these are calendar days. These are not business days. They're calendar days. So that doesn't give a facility a lot of time if they're struggling with a removal.
Hi, this is Beth. I'm going to respond, and then Patrick and Linda and Terry from CMS may have subsequent comments. When you have an immediate jeopardy on hand, you want to take immediate action as soon as possible to remove that immediate jeopardy. Depending on the scope and severity and the circumstances at hand, there are facilities that might be able to remove immediate jeopardy immediately, but there are facilities that may take a couple of days, and there are facilities that it may take a week. We encourage to address it as soon as you possibly can, but you want to make sure that your actions are addressing the immediacy, because if the state comes out and you say that you removed it and you haven't, then it cannot be removed, and your 23-day time track still keeps running. Patrick, Linda, Terry?
Yes, that is correct. We concur. But just in addition, I wouldn't want to conflate the two. The 23 days is a termination action. The removal of the immediacy is more specific to the safety of the resident. So I would try to remove the immediacy to protect the residents as soon as possible.
Thank you.
Okay, Jennifer, did you have any follow-up comments or further questions?
No, that's it. Thank you so much.
Thank you. I'm going to go ahead and mute your line, and we'll go on to the next question. Let's take from Keith Fire. So let me unmute your line. And actually, it looks like I can't unmute Keith, so I'm going to have to ask his question for him. So this says, do you believe this change will result in more or less IJ cited?
This is Beth. We can't predict a number of immediate jeopardies. This new process, what it does do, it helps the state agency, it helps the providers, and it helps CMS clearly understand what the non-compliance is. You can't call an immediate jeopardy unless you have non-compliance. That's why it's in that first box of the template. It clearly helps the state and CMS and the providers understand what the serious or likely serious harm is. And it also clearly helps identify what the immediacy is of the situation to understand immediate action needs to be taken by the provider to remove it. With this template and with what I just described, it may be that there may be less IJs called, or it may be that there might be more IJs called simply because the way the structure and the framework has been put together, it helps all parties clearly understand what goes on. So there can't be a number there that's defined. Thanks for asking the question.
Okay, I hope that answered your question, and I'm not sure why I can't unmute your line, but go ahead and type a further question if you need clarification there. Next, we'll go to Christina Wells. Let me find you to unmute you here. I'm not seeing them. Oh, there we are. Okay, here we go. It's a long list of people. Sorry, folks. So, Christina, I have your line unmuted if you would like to ask your question.
Thank you. So we were wondering, in the 2014 Appendix Q, it included an Attachment A for the ICF. Can we assume that all ICF specifics have been incorporated into the new core Q appendix?
Yes, this is a core Q appendix now that is supposed to be used by all 17 of CMS's programs. There is a special supplement that is for the skilled nursing facility nursing home. That's in addition to the core Q, and that's there to help with understanding how to recognize triggers, how to follow the process of the team, what they do in plan, and carrying out in investigation. There also is a special component for the CLIA program.
Okay, I hope that answers your questions. Any follow-up, Christina, before I mute your line?
No, thank you. We're good.
Okay, thank you. Okay, next it looks like Edith Morrison has one more question, and this is, all injuries have the potential to cause serious harm. If there's no determining length of time for the complications, how is that determined?
Linda and Terry, would you be helpful in answering this question, because you had a really great example there that you brought out about the template, and that might help answer this question.
Could you repeat the question again so we make sure we're clear?
I sure can. It says all injuries have the potential to cause serious harm. If there's no determining length of time for the complications, how is that determined?
I think we're having a hard time determining what the question is regarding the time frame.
Let me try one more time to unmute Edith, and let's see. Oh, Edith, can you hear me?
Yeah, I can hear you.
Oh, perfect. Now maybe you can expand on your question a little bit so we get a little bit more understanding of what you're trying to ask.
I had something that was kind of very similar to this just recently. The patient was on hospice. She had a fall, and she had a significant injury, in my opinion. But because she was on hospice and had already been declining, she passed away later. My question is, how do you guys determine a specific length of time in those instances? Because that fall could have been, for instance, if she would have broken something, that could have caused her death, but if she died 6 months later, how do you guys determine if it was related to that? Does that make sense?
Yeah. So an IJ could be indicated for past non-compliance. Obviously, the immediacy wouldn't be there, but the failed practice would still be there. And then the survey would also have to look to see if any current hospice patients, and specific to your question, are affected, are currently affected. We would hope that the facility identified the issue at the time of the resident you're talking about fall and corrected.
Oh yeah, that happened real quick.
Yeah.
And this is Patrick. I just want to read the definition of likelihood. Likely means that the nature and extent of an identified noncompliant creates the reasonable expectation that an adverse outcome resulting from serious injury, harm, or impairment. And so, you know, when you're looking at clinical medicine, you're talking about primary, secondary causes. I think what's reasonable, whether or not, you know, a scratch could lead to a secondary infection. We don't want to hold facilities, you know, responsible for something that could, you know, develop, you know, months down the road. So what's reasonable? I think the team would have to come together and have that discussion. And the key is, does it require an immediate action? So a fall without a fracture or a fall with a fracture, what is the immediate action to remove the risk of falling, not necessarily the breakage of bone?
Okay, that makes sense.
Okay. Any other questions, Edith?
No.
Okay, I'm going to go ahead and mute you again, and we'll move on to the next one. Let's take this one from Terry Robertson. I'm going to just find you on the list here and unmute you. Okay. Terry, I think your line's unmuted if you'd like to ask a question. Oh, maybe not. Some people might not have mic capability, so I'll just read it. Terry says, I am still unclear on number 1. What written notification does the provider receive in writing that an IJ has been substantiated, and when? And then further, how does the facility know when the IJ has been abated?
This is Beth. I will start out, and Dina, feel free to step in, and as well Patrick, Linda, and Terry. We had described how we have to first determine non-compliance, second, that there's serious harm or likely serious harm, and injury, impairment, or death that's going to occur, and then immediate action has to be done. And it's written on the IJ template, which the state agency survey is supposed to give to the facility at the time they're calling the immediate jeopardy. Subsequently to that, the state agency will be sending a notice out to the provider that there has been an immediate jeopardy that's been called. Depending on the timing and the circumstances, whether it's a full survey or a complaint investigation, that could be put into the notice that accompanies the 2567 statement of deficiency. And then CMS will have their part on how they notify. Terry, Patrick, Linda, I'll let you speak to that.
Yeah, typically what we would do from a CMF RO perspective is we send out a letter, a certification letter, basically with remedies, appeal rights, and IDR rights, explaining that the termination has been extended from 23 days to 90 days, or 180 in the case of nursing homes. So the facility would receive a letter corresponding the IJ has been removed and the termination has been, the termination date has been extended.
Okay. I don't have the ability to unmute that person, so hopefully we answered their questions. If not, type in the chat box and we will expand further. So next, it looks like Keith Farso has a few more questions. I don't have the ability to unmute their line, so I'm just going to read the question again. In the scenario where all 3 components must be met, could the facility have removed the IJ prior to the survey coming to the facility? And then he added, as an example, the resident was injured, the staff involved was fired, and all other residents have been reviewed for potential injuries.
This is Dina. It is possible that that could happen, that there, at the time of the event, whatever occurred, it was significant and serious, and the facility took action right after to remedy and address those issues. So that, yeah, definitely could occur. And sometimes as a state agency, we would look to see if anything currently, if anybody was still currently at risk, or if the failed facility practice around that situation has been fully corrected, as mentioned earlier about past non-compliance. So we would look at that option as either currently there are still issues and it may not be immediate any longer, but it may be a citation that still is not fully corrected. So there would be a 2567 that would reflect that, not at an immediate jeopardy level. Or secondly, if the state agency got out there and the facility had already done everything, they had systems in place, they have ongoing monitoring for this not to happen again, and they're actually in substantial compliance at the time that we are on site, then maybe a discussion about past non-compliance might be the option for that.
This is Beth Schlummer. I think it's important to recognize that every situation can be different and the fact patterns and evidence can be different. For an event that occurs, an incident, and the staff member, if they're involved, is removed or let go on the action of the facility's behalf, and the events there you've dealt with the resident, that in itself does not remove immediacy, depending on what the circumstances may be. We have to remember that the immediacy is facility practice. A resident that has passed away or a resident who's gone to the hospital does not remove the immediacy of whatever occurred. Again, it comes back to facility practice. So if there's an event occurred and something happened with a staff member, you need to go out and evaluate facility practice about the particular delivery of care and service that was involved in the event to remove that immediacy.
Okay, I hope that answered your questions, Keith. If not, type in the chat box again. Next, I'm going to go to Tashini McNeely. You've had your hand raised, so I'm going to unmute so you can ask your question. Hopefully you're still here. Okay, you're unmuted, Tashina.
Yes, thank you. So my question is, how do you decide when to run through this template? Does every single F tag that the facility has get looked at under these eyes now?
This is Dina, and I'll start, and then if anybody else wants to pitch in, they certainly can. So no, not necessarily. We would not be looking at every single F tag as either somebody is out there on a complaint investigation or on the long-term care survey itself. So we're looking for triggers, as we had mentioned in one of the slides earlier in the slide deck. We're looking for triggers. So we're looking for things that really would make us concerned. Oh my goodness sakes. So here's an example. You're going around looking in the environment, and there's, you got the electric heat, the baseboard heaters that are usually under the windows in resident rooms. And as we're going along the tour or going in as a survey team and looking at residents for interview, we notice that there are things that are dangerously close to those baseboard heaters, and or touching those heaters. So there's a trigger. So what we may want to look at is we may want to get a little bit more information. So we go over there. How hot is that heater? Is there any damage to the thing that is close to it? Is it a leg of a chair? Is that getting hot or looking like, that could be a fire hazard? Are there cardboard boxes that are touching that heater that could ignite a fire in the future? So those would be the things that we would do, but it's always about a trigger. We don't just take that template and plug it into every citation. It doesn't really fit. We would look for certain things that would make us want to investigate further. Does that answer your question?
Sorry, I muted her. Or nope, she's self-muted. So we can't hear your answer. Hopefully that answered. If not, go ahead and ask again. Okay. Any other hand raises, other questions? We have just a few left. So if you have a question to ask, go ahead and raise your hand in the webinar and we'll get to you next. So next we're going to go to Jomar Balgos. He's a state agency staff. Jomar, your line is unmuted.
Hi, can you guys hear me?
Yep. Yes.
My question is regarding the need for immediate action. If the facility, after communicating with the provider, surveyor communicated with the provider the potential concerns or division practice, they acted and fixed the concern immediately, will still this be considered a need for immediate action?
Once you call the immediate jeopardy, if you have evidence that the provider removed the immediacy, remember the failed practice of the facility is what's creating the immediacy, then we would have to have received a removal plan from the provider before the state agency does an investigation to determine if the immediacy has been removed. So what this is what I had mentioned earlier, there can be some immediate jeopardies that can be removed quickly, and then there can be some that may not be moved as so quickly. But as Patrick had mentioned earlier, we encourage that you take immediate action to try to remove it as fast as you can to protect the residents.
Okay, Jomar, does that answer your question?
I think I did. The reason I just want to clarify that is because, you know, I would like to put an example. For example, smoking, 689, we, for example, observe residents with smoke burns and they have history of CVA with physical and mental impairment. And after communicating that concern to the provider, for example, they do an assessment, they updated the care plan and did a whole 9 yards, will still that be considered as the need for immediate action?
This is Beth. Thank you for asking the question. I'd just like to reemphasize the event itself and the resident occurring itself is not necessarily removing immediacy. You have to focus on the failed facility practice. You have to look at the resident involved. You also have to look at any other residents that may likely sustain or have also sustained serious harm, injury, impairment, or death.
Okay. Sorry, I have it. Okay, Jomar, does that clarify it a little bit?
Yes, thank you.
Okay, thank you. I'm going to go ahead and mute you. And then I think I'm not seeing any other questions except one clarification from Shanna Privet. She is part of our ICF team here at RCS. Let me just find you and I'll unmute you. Okay. Shanna, did you want to make any comment or question for clarification? Okay, maybe her audio is not working, so we'll go ahead and mute her again. Okay, so I guess we're coming to the last call. I'm not seeing any other hand raises or questions. Let's just give it just a couple more minutes for people to chime in if they have any other questions. Okay, Ben, I'm not seeing any.
Okay, I would just like to, Laura Hoffman from Leading Age and Lena Madrid there from WACA. Do you have any questions before we close up here? And thank you for giving us the opportunity to do this presentation.
This is Elena. I have no questions. I just want to thank CMS and RCS for putting on this webinar for our members. It is greatly appreciated. Thanks again.
Okay.
Laura, did Laura have any?
I'm not, maybe her audio isn't quite working. 'Cause I don't hear her chiming in.
Patrick, Linda, and Terry, any closing up comments here?
Yes, this is Patrick. I just want to share my appreciation for RCS and all of the participants. This has been something that I know RCS has been working on for quite some time. Fantastic job. And again, thank you. I think this was really helpful.
Okay. Dina, any comments?
No, thank you, CMS, for your contributing pieces to this. We appreciated you helping us through this presentation. It just made it, I thought it was a fantastic experience for everybody to hear the different perspectives.
Training unit, Jerry, Christine, Marcy, Becca?
I don't think we have any closing comments, but I did want to let you know Laura chatted. Her audio is not working, but she wanted to express her thanks on her behalf.
Well, as Dina had presented, this is Bet again here, as she presented in the startup of this presentation today, CMS had started a few years back pulling a work group together to try to identify where we needed to move forward and revise the Appendix Q. The Appendix Q that was there was more in the area for and utilized more on the nursing home program than to help the other 16 programs CMS has oversight of. So this new Appendix Core Q I find is very helpful, and I've heard from providers it's very helpful. I've heard from CMS and RCS staff it's very helpful. And so I'd like to close up here with, not going to the next slide. There we go. I'd just like to close up here with some acknowledgements here. Lisa Tripp from the CMS Central Office has been really instrumental over the past couple of years, along with a lot of other CMS people, in working on this revision of the Core Q, and she was helpful in giving us information to put these slide decks together, along with the Region 10 office who helped us. I'd like to thank Dina Long-and-Grimes here. She's our nursing home compliance specialist, and she has done a lot of work in helping us put this presentation together today. So thank you, Dina. I'd like to thank Alina and Laura, because in the upfront when we were planning on this, we actually started talking about it probably almost 2 years ago, having some type of training put together that was joint and getting their input on this, so I appreciate that. I'd really like to thank the Region 10 CMS team, Patrick Ripp, Julius Bunch. He's not on our phone today, but he was helpful as well. Linda Harris and Terry Oki. They're a great team to work together today, and I appreciate all the input they had in our PowerPoint presentation. I'd like to thank Steve Chickering, who is the Area Regional Administrator for CMS. He has oversight of the Region 10 office as well as Region 9 and Region 8, which they call a makeup of the Western Consortium, and he also had input in this. Trish Harmon, who is our administrative assistant here for our director, Candace Gehring, she had an input with this. I'd also like to express appreciation with Candace Gehring, our director, who was able to allow us to have this presentation come together today. And then I would like to thank Ty Nguyen, who really helped us set up this webinar and all the logistic parts of it. Rebecca Kane and Christine Kubiak today, who's really been helping along with Ty with the logistics of this, and Christine Kubiak and Jerry Jones, who are nursing home program trainers. Everybody had some way or form or input into this today, so thank you, team, for your work. I also want to thank the providers. Thank you very much for your attendance today, and any of our residential care services staff who attended today. I appreciate your attendance. I appreciate your questions, and hope we were able to get those answers to you. If there are any other questions that are coming up through the associations, please share those with Alina Madrid and Laura Hoffman, and they can get up to us, and we'll try to answer your questions.
And this is Dina, and last but not least, we need to thank Beth Schlemmer for all of she has done for helping us with this presentation, because she has been very instrumental in getting the slide deck going, and then all of her great parts today that she contributed to. So thank you, Beth.
You're welcome. So if there are no further questions, I believe our presentation is completed, and it will, Ty, it's going to get posted. Yeah, it will be getting posted, and we will let the association know when that is available. So thank you, everybody.
Thank you, guys. Have a great day.